All right. So, and lastly, okay, good, good, good. All right. Well, I would like to thank everyone who is in attendance this evening for NAMI New York City Staten Island's informational webinar, especially now during May is Mental Health Awareness Month. My name is Pete Schiffman. I'm the president of NAMI Staten Island. I'm proud to present our panelists for this evening from St. Joseph's Medical Center Crisis Respite Services. We have Angela King Brown and Angela Jordan. And just a little bit of housekeeping. Anybody has a question or comment, they can use the Q&A or they can use the raise hand feature. And we will get to that after the presentation, okay? So without further ado, I thank you ladies for attending and please introduce yourselves.
Yes, thank you so much, Pete. Again, my name is Angela King Brown. I am the program supervisor for St. Joseph's Medical Center Crisis Respite in Staten Island. And with me today, I also have one of the crisis staff members. Her name is also Angela, Angela Jordan. So the two of us will kind of share a little bit about what we do and who we are and how to obtain our services. We may also have another staff member may chime in, hopefully before the session is over. So we are, again, Crisis Respite. We are the only ones on the island that I know of. We started St. Joseph's Department of Residential Services. So St. Joseph's is pretty big of the medical center. There is the hospital in New Jersey, and there's also located in Westchester. So the Department of Residential Services of St. Joseph's Medical Center was established in 1968. Since that time, the department has expanded to provide a full continuum of residential housing options, from transitional community residents to permanent housing. So that person with mental illness and other special needs can live independently as possible. Residential services provide housing options in 4 boroughs, like I mentioned before, New York City, as well as Westchester. The picture that we have here is actually our building. It is, we call it Tompkins Residence, under Tompkins Harvey, and I'll talk a little bit more about that in the slide. Crisis Respite. Since April 1st of 2016, we have opened our doors. We are a 3-bed facility in the community, in the West Brighton community. We are funded through the New York State Office of Mental Health, State of Office of Mental Health. We provide a temporary residential setting. This is the building I was telling you about. There's a total of 21 people who actually lives there more long-term. It is a residence, a congregate care residence, where we service individuals ages 45 and up, with special attention given to medical issues and coordination of psych and medical. So it's a pretty much round support for those individuals. So we share that space with them. And that was us. We, like I said, we opened up April 1st. We've been around for a couple of years now.
That's awesome.
And this is a question we get: what is crisis respite? And the goal here tonight, and just hopefully everyone can kind of spread the word, we are here. We're here to help. A lot of people don't quite understand what respite is and how to go about it. So crisis respite provides an alternative to hospitalization for people experiencing or with emotional crisis. It is a warm, safe, supportive home-like place to rest, to recover, to get support when needed that can't necessarily be provided in the home. The range of stay, a person can stay from 7 days to 14 days, providing an open door setting. So a person can go in and out, they can continue with their daily lives. If they have appointments, if they see a certain friend once a week, we don't want to change that routine. We want to provide as much support. The great part about crisis respite, it is peer-ran. There's trained peer specialists and non-peer work. We work with individuals with them to succeed, to overcome emotional crisis. We also offer activities, 24 hours, self-advocacy, education, self-help, training, whatever that person needs, whatever linkage we can help them with, we will do our best to do that. I do want to say this one disclaimer that crisis residence and crisis respite, we are not alternative to housing. Sometimes we do get faced with challenges of people that are homeless, that do live on the streets, but that doesn't stop us from giving services to each and every person that walk through our doors. But we don't have the resources to find housing or put them in the housing environment, but we will try our best to do what we can to assist them. And here I talk a little bit about what the 3 programs are. We have residential crisis support, respite care, and crisis respite. So crisis residence is something that is new among pretty much all of the crisis respite programs, which means they're transitioning to more long-term care. They offer the same exact supports as a crisis respite, but it's now managed with insurance through the Medicaid, managed care, private insurance, and they're basically paid through the insurance. So the support is still there. They get to stay a little bit longer. That's the difference between a residential crisis support and crisis respite. Whereas though crisis respite, a person can stay from 1 day or 7 days up to 14 days. We do not ask for insurance information at this time, but the residential setting do provide that. Respite care has been around for a long time, and sometimes people do mix up the two. Respite care is a short-term relief for caregivers. It is a service that's offered to give a person a break, a caregiver ranging from a few hours to a few days. Sometimes the caregiver just need a little bit of a break in between. That's the difference between the 3 programs. What does crisis respite provide? Peer support. There's someone there 24 hours, 7 days a week. If the individual can't sleep, have insomnia, they need to talk to someone, we're there. There's always going to be someone there. Self-help, social group support. Like I mentioned before, we are in a shared space with the Harvey residents, and there's a total of 21 people who live there. So there's always somebody there. There's always somebody there to conversate with, to talk, to smoke a cigarette, to drink some coffee with. There's always someone there to help. We've also provided wellness self-management, self-advocacy, recreational activities, any linkage, like I said before, to medical and psych providers. Oh, I haven't been feeling too well. Or when was the last time you went to the doctor? Oh, I don't know. We help with that. Like, okay, are you connected to a care coordinator? Do you need, when's the last time you went to the doctor? Do you want us to support you and make an appointment? So these are the things that we can help when a person comes to crisis respite. And as you know, is a national need. I actually took this from one of the articles I had read a while back. 1 in 4 adults, about 62 million Americans experience some form of mental illness during the course of a year. Of those, about 14 live with a serious mental illness such as schizophrenia, major depression, or bipolar disorder. According to the data from the National Alliance on Mental Illness, more than half do not seek treatment in many cases because they do not know where to find help. And I do hear that often when we do receive individuals and they're not in treatment. They don't know where to go, or I may get a phone call from a family member or from a friend that just want to know where can they go? What can happen? What can be provided for them? So crisis respite, this is what it looks like. This is our hallway like you've seen before. Each room is a single room. Each person will have their own room. The key to their room, it is a shared space. So they will have to share the bathroom, the TV room, and the kitchen. We do provide meals, so you get to eat together as a community. And this is our TV room as well. Our television is a little bit bigger than that now. We upgraded. So the criteria to get into crisis respite is pretty simple. A person must be 18 years of age and older, exhibiting symptoms of, it says on here, exhibiting symptoms of mental illness or psychiatric crisis. It may vary. Someone may have a change of medication and they're starting to feel a little bit more unusual than they have been. They don't want to stay home because they don't feel really comfortable enough by themselves. Come stay with us. No intimate risk to the safety of themselves or others. We have to make sure that they're stable. The individuals experiencing challenges in daily life that create risk of escalation of psychiatric symptoms that cannot be managed in the individual's home and or the community without on-site support. And the most important thing, the person wants to come, the individual wants to come. We do get calls from time to time of, say, a housing provider or a family member, oh, this person needs to come. And when we talk to them, I didn't agree to that. I don't want to come here. And they have that option. And the beautiful thing about us, they can leave whenever they want. Even though it's a 2-week stay and they decide after 7 days they feel a little better and they want to go home, they can. We're not holding a person down or holding them back. We want to make sure they left different than the way that they came in. Acceptable referral streams. How do we accept referrals? Anyone can make a referral. We receive it either through fax or email. A referral should always be received prior to admission because it has to be reviewed. Hand-delivered referrals will not be accepted. Most times people will call and we will send over either by fax or email. And a lot of outpatient programs and agencies and hospitals do have our referrals already. And we're making sure by doing stuff like this and outreaches that programs do have them. We do not encourage walk-ins. So we don't want to get that person disappointed. We don't want anyone to walk in and we don't have a bed available. We will try our best to see if there are other respite programs that may have an opening, but it's a process. It's a process and we can't guarantee. So once a referral is made, we talk to that person over the telephone. We do a telephone interview. We kind of see what's going on, what's the crisis, how can we help them? Also, we talk about where do you plan to go after your discharge? And if there's any coordination of care, is there a care coordinator? Is there AOT? Are there other elements of your support that we need to know of? So we make sure that everything is wraparound support. So everyone is involved, because that's very important. A referral enrollment form is submitted. We do ask for COVID-19 results, and I don't want people to get nervous like, well, what if I test positive? You test positive, you test positive. We just put you, we isolate you. You're gonna be in your room, we make accommodations. I always tell people they get catering service because we'll bring the food to the room. We'll make sure that that person is in a comfortable environment. Additional documents with the referral form and the referral. We do ask for psychiatric eval, psychosocial or medical exam. It's not required, but if it's available, we will be gladly to accept it because it gives us a little bit more insight into that individual and how to better treat that person. If they have a list of current medications, that's very important for us. We need to know what medications they're on in case of any kind of emergencies. And if they need supports on medication, if they need to have a conversation about medication management, that's very important for us to know. The response time for us can vary from 12 to 24 hours or even sooner. If there's a bed availability and everything have been submitted, it could be as quick within that day or within a few hours. So once a person come in, check-in time, we provide a tour, we do a self-preservation test, meaning we want to make sure the person can get out in case of emergency. We complete the paperwork in the registration process, we take a picture so the other staff can know who that person is. And we like to introduce that person to everyone so they can know who they're walking past when they're walking down the hallway. They know who the staff is, they know what the schedule is. If we're leaving out of the day and I'll go and tell them like, oh, hey, I'm leaving, my shift is over, but you'll see me in the morning, I'll be here at 8 o'clock. And Justin is here, he'll be here tonight, and we introduce the the guests to everybody. And we just allow the guests to settle in because they're here for a reason. And we want them to get the rest that they need. And we'll work on the recovery, whatever tools we need to work with them on. While they're there, we like to talk about events and activities, from cooking on a budget to managing my symptoms, spirituality. It can go on. We have some of everything. We want to make it fun. We want to make it enjoyable. We also may do meditation 101. I like to do the visual meditation, and every now and then individuals that come back, they're like, you know what? I like that visual meditation because when I'm stressed out and people working my nerves, I think about the blue water or the mountains we was watching on the TV as we was trying to relax. So those are some cool things that we like to do there. We're always looking for activities and events to host. We recently had a Women's Day History Month event, went really well. And then if you see on the left, we had the three amigos of mental health. He is a comedian and he goes around and he just spread a lot of education and inspiration about himself and his lived experience and how he worked through everything to get where he is and all of his wellness tools and his challenges. He's really amazing. And he's called the Three Amigos of Mental Health. He actually auditioned for America's Got Talent as well.
Nice.
The impact of peer specialists. Ms. Jordan, I'm gonna put you on the spot. Can you talk a little bit about working as a peer? A little insight.
Well, as a peer, what I bring to the table, what we bring to the table is lived experience. And we bring also respect and compassion. And like Angela was saying, it is short term right now. So you had to be careful not to try to squeeze everything in. And if sometimes we get guests that want to talk and we have people available 24 hours, so they're always able to have someone to speak to. And sometimes we get just the opposite where people, they want to be alone, they want their solitude, and they can do that as well. We offer like 3 meals, and that gives the guests a chance to talk to the other residents in the house and communicate and socialize, which I think is good when you're feeling down. You could talk to other residents, and that's about all I have right now. Did I leave anything out, Angela?
Nope, you did a fabulous job. Thank you. And then the picture this is the staff. We're missing one person, but she was in the other picture. But this is the peer staff, the crisis respite staff. And we enjoy what we do. Everyone has been there for quite some time, since 2016 and a few years after that. And each staff member can tell you that, hey, I enjoy what I do. I enjoy when I come in every day and meeting with someone. There may be challenges, it may be some heartwarming, some not so heartwarming, but we enjoy what we do. The principle of crisis respite. We are recovery oriented. Services are strength-based and determined by the individual's own path to recovery. Person-centered. The strength, the need, the preference, experience, and cultural backgrounds of the individual are reflected in the services and supports. I never forget the one time we just started and I was doing a rap plan with the individual. And I asked this individual, well, when you're not feeling well and you feel as though you need to go to the hospital, what hospital you like to go to? And they looked at me like, what you talking about, Willis? Why you asking me that question? No one ever asked me that question before.
Right.
I was like, you have that choice. And this person looked at me like, really? So we want to let people know you have a voice. This is you, this is your health, this is your wellness. So we have to treat the individual just as if it was us. I know I have a particular hospital I like to go to. I don't like certain ones. Everyone should have those options. Also, just being trauma informed. Services are provided with the concept of understanding trauma and recognizing or responsive to the effects of trauma. Being culturally and linguistically, tongue tie here, competent with that. And most importantly, like we mentioned before several times, peer support. And the staff are qualified, they are certified, in fact. Certified peer specialists. I know we have one who has their provisional, but everyone else has been is certified. So I want to share a little story of an individual. They gave me permission to share the video. I used it in a conference a while back. And this individual name is Laura. And she was a former guest who stayed for about 10 days and was facing some relationship challenges what began to affect their mental health. As a result of her stay, she learned about mental health activists. We talked a lot, such as Howie T. Hart and Patricia E. Deegan. She became intrigued and she was so inspired that next thing you know, this individual was already online and completed their peer advocacy training, their peer certification within 6 months. So that means something, that's some substance to it.
Hi, my name is Laura. I just wanted to talk to you about Respite. It's a great place to go when you feel like life is getting to be a little too much. And I just wanted to tell you that the staff members are wonderful. And like I said, it's a great place to go when you're getting really stressed out. I myself was getting stressed out at home and I needed to get away for a while. And I was gone in a total of about 10 days. And I appreciate everything that the staff helped me with. There was one particular person, his name was David, and he helped me a lot. I would ask him, can I talk to you? And he said, okay, come on. And we went into a room, very private, and he made me feel very, very comfortable. And he tried to help me the best he could. And I said, thank you so much. And it was an issue at the time, I don't mind saying, with my boyfriend. And we were arguing a lot. And I wasn't sure what I wanted to do, whether I wanted to stay or I wanted to go. And so it made me have more of a clearer mind to decide what I was going to do. And fortunately, to my benefit, it was very helpful because when I went home, we both decided to go to couples counseling. And I thought that was the best answer that I ever heard. And I said, let's go. And we've been doing that for over a year now. And it's been extremely helpful. We're getting along great. And I love him very much. And he's been fantastic. Hi, my name.
That was a beautiful testimonial.
Yeah, it's great when you hear stuff like that. Reminds you, okay, this is why we need respite.
Exactly.
And also have another story, and this one really it hit deep. I was like, I gotta share this story, and she was like, oh yeah, I definitely want to tell people about this, and I'm going to tell everyone. So this individual, Augustine, is a 38-year-old native of Staten Island who was hospitalized 3 times in a year due to their mental health. And they stated at the time they was in a hospital, they felt more isolated and overwhelmed. And we also operate as a step down. I don't think I mentioned that before, but if the individual is no longer need inpatient care, instead of getting thrown back into an apartment where the apartment has been closed up for 2 weeks and The food may have spoiled, and it's a lot. It's a lot to process. So sometimes coming to us and doing like a soft transition, those things help. So while at Respite, staff provided peer support. We walked in the neighborhood. We did things that kind of just helped this individual get out of their isolation and out the shell. And it was great. And the feedback that we heard later on with their provider, it really like, wow, this really helped.
Hi, my name is Augustina. I'm from Staten Island. I've been hospitalized 3 times since this year for my mental illness. I found out about Respite through my therapist. She told me that it was more, it's a step down from the hospital, and I really liked it. Every time I took a hospital stay in the hospital, I felt like the nurses were very unprofessional and laughing at times, and different people's sicknesses, and very uncomfortable. I stayed isolated in my room, which I isolate a lot when I'm in depression. Nobody came to get me, which over here the staff, Angela, and also a guy named Chris, that's part of the Respite program, came, and he came and got me out of the room. We took walks and I went shopping, and I socialized with the peers that live here and got along with everybody. Everybody was so friendly. I didn't feel any of my symptoms. I feel 100% better leaving this place. I'm so glad I found out about Respite, and I look forward to coming back to Respite if I ever have any sickness again, because the hospital stays just, I feel, just give you medication and send you back in a room, but here people are so nice and they actually care for you. Hi, my name is
So after crisis respite, the staff, we conduct follow-ups. We want to know how a person is doing. We don't want an individual to come and then poof, be gone. We actually we care. We want to know, are we effective? Are we doing a good job? Even before a person walk out the door, we'll do a survey. And I'm constantly checking in with every single person that walked through the door. How has your stay been? Are the other residents meeting with you, talking with you? Are they nice to you? Are the staff members engaging with you? You know, ask these questions. I like, be transparent. You're only going to help us and the next person. So staff conducts a 24-hour discharge follow-up in addition to a 15 and 30-day. Former guests are asked about their stay, what helped during their stay, what improvements they would like to see, and just continuing the dialogue about their wellness, their RAP plan, which is their Wellness Recovery Action Plan. Feedback on the follow-ups we received, I found the staff helpful and the environment to be therapeutic, and I am following my RAP plan. Sessions with Angela has helped me to see that there's hope for me. Thank you for running an effective, warm-hearted program. So these are just a few of the things that remind us like, hey, this respite is good. And it's not just us, it's pretty much, it's all the respites. The respites are in every borough. I'm gonna go into that. But we are the ones that are here in Staten Island. I always say the forgotten borough. Like, there's one on Staten Island? Yes, we're here, we're here.
Mhm.
This is a text taken from the National Empowerment Center. In times of crisis, people feel alone with their anxiety, panic, anger, frustration, and depression. One of the goals of peer-run crisis respite is to provide connection and relationships that can lessen the intensity of these feelings. These non-medical alternative programs offer a comfortable, non-judgmental environment in which one might be able to process stress, as well as explore new options. So that right there just it speaks everything as to what crisis respite is and what we do here in the Staten Island Crisis Respite. And like I mentioned before, they are respites, crisis respite, residential crisis supports in pretty much every borough. We are in the process of transitioning to a crisis residential, which will give an individual more time rather than 14 days or a shorter length of stay. But if you call New York Wells, sometimes people may call like, oh, everybody's full. You can call New York Wells. Each day, all the respite programs have to give a census of how many beds we have available. And I tell every time a person calls, hey, call New York Wells. Even if we can't help you, call New York Wells and we'll see, let's see what else there is out there. I'll give the number to the other respites, call around, call each program to see what's available. They may not have something now, they may have something tomorrow, you never know. And there in Brooklyn, there's SUS and OHEL. In Queens, there's TSI. Manhattan has ACMH or Community Access, and Staten Island is us, and in the Bronx is Riverdale. I think they just changed their name to Mosaic. This is us, and this is how we can be reached. Staten Island Crisis Respite. We're at 1150 Castleton Avenue. We do encourage people that are either on the fence, come take a tour, or you just want to come check it out. Come take a tour, give us a call, or like, hey, I want to come see the place. I want to see if there's a connection, if I feel comfortable. Because sometimes people are hesitant about coming into a new environment, especially if they live on their own in the community. Not really sure if they want to come into a community setting. I always encourage people to come. And this is our website. We are St. Joseph's, and that's pretty much it. And Pete, thank you for giving us the opportunity to present and to talk about crisis respite. We just want to get the word out and let everybody know we are here. We are here to provide support.
That's tremendous, and thank you so much for that very informational presentation. I mean, it just sounds like a tremendous service, and it's true. It's probably not really well known, or possibly well known to Rumsey and Northwell, but not to folks in general, you know?
Right.
So before, if anybody has a question, they can just put in the Q&A or raise their hand or something like that. But I had a question. We have family members that are oftentimes concerned their loved ones are possibly not staying really long enough in the hospital.
Mhm.
So this, as you said, so this could be an option possibly. So if a family member knew about your service and felt and their loved one was in agreement, what would be the best step for them? For the family member or the loved one, do they just tell the people in the hospital that please?
Yes, that would be an excellent transition. That's an excellent transition because then they are provided a little bit more support services, and we're able to observe them. And we know it's like, hey, they still, from what we've been told, they still don't seem like they're quite themselves. We can at least say, hey, let's do some kind of follow-up. And just having a conversation. Some people do really well with that, or sometimes we have the person on their own, like, hey, I need to go back. I want to go back to the hospital. And then sometimes that second time around end up working. And sometimes it works out perfect. Like, hey, I just needed to kind of get out and I can manage. I just need help managing medication so I could kind of get on my own, just trying to fill things out.
Mhm.
No, that's excellent. So what they would do, the social worker can make the referral, can call before they even set the discharge date. And like, hey, we have a person we're going to discharge soon. And I would ask them, well, how soon are you planning to discharge? And I'll see if there's a bed available, and we will coordinate for the next bed if we don't have a bed currently open. But no, those are perfect opportunities to transition to respite as a step down.
Okay, sure. You know, we've been following the news lately about the budget and plans for expanded crisis respite services,
Right.
but I'm not really aware of how that breakdown would go. Would there be any more expanded beds or services for Staten Island, perhaps?
There have been conversations about it, ongoing conversations. And I know that's one of the reasons why we're in the process of transition to residential services. So we can provide more stay, more services. I know there were some agencies that were looking into opening up a respite, but I haven't heard any updates if there were any more. Um, so hopefully the budget will include, because there have been discussion of additional funding to start opening up more, or open up more intensive respites as well.
Mhm. Sure, sure. And I hope that that works out, and I hope the forgotten borough is not forgotten.
Exactly, exactly.
Okay, we have a question in the Q&A. If I may, I'll read it. It's, how do you deal with medications and compliance?
Ooh, good question. Uh, we do encourage the individual to have their medication. We can support, meaning if the person has, we can provide a pill box and that person will refill the medication. We will support them. I would take on that task if they don't have like a provider that's already doing that. If they don't have any connections with supports, then I will be to take the lead and like, okay, let's do your medications. And even at the beginning of the referral, the conversation I would have with the individual is, how is your medication? Are you taking meds? How do you feel about your meds? What are you taking? Kind of get an assessment as to where that individual is, to see what kind of support is needed to be in place. If that means the staff need to remind that individual like, hey, it's 6 o'clock, it's time to take your medication. And they would go get their medication out their room. They would take it with staff like, okay, you took it, good. And just even having a conversation about medication, if that's one of the issues or some of the concerns.
Okay. And to build on that, if a person was, say, adamant that they weren't taking any medication, but was not a danger to themselves or others, would they be able to stay within the respite?
Absolutely. Yes. Yes. We don't force anyone to, there's a reason. And then there's also conversation about that. Well, let's dig into that a little bit more. Some people are able to manage without medication. Some people need medication and don't take it. It's like,
Right.
okay, so what coping skills are you tapping into? What are the warning signs we need to be aware of if you're not doing well? So that's where the RAP plan and the conversation safety plan comes into place, how we can be a support for that individual. But no, that's totally fine. We've had quite a few individuals come through the doors that don't take medication, but sometimes can benefit from it. But a person is ready when they're ready, but we can provide as much education and support as possible.
That's tremendous. I will say that at NAMI New York City Staten Island, we, or definitely I, am big proponents of peer specialists. And we are fortunate that among our small but mighty ranks, we have a few wonderful peer specialists and one that's just becoming a peer specialist.
Oh, wow.
So the model sounds absolutely wonderful, and I'm glad the service is being offered, really.
Yes, yes. All of the respite programs, which is also great. We have a training that everyone does. It's called intentional peer support. And the lens in which we actually have to train is eye-opening. It's a 7-day intense training that we received from an outsourced company. They traveled from Atlanta. They came to New York, and all of the respite programs staff had to attend. Actually, Angela and I, you remember Angela, the training we went to? It was
Yes.
really, really good. It gave so much insight as to not only how to work with someone, but how to work within yourself. And just being mindful to remember everything, the tools that we learn, understanding of person mutuality, understanding, being comfortable with being uncomfortable. I still remember that to the T, and expressing how you feel and being able to understand an individual for where they are. But what I really enjoy about it, for the staff, we actually have to do, we are encouraged to do co-reflections. Co-reflections is before we do a staff meeting or on their own, the staff get together and they talk and they brainstorm without management involved or supervisors involved. It's their own safe space to have a conversation about the services or how to better support an individual get through something, or if they feel they're triggered by a certain person we're serving, how to process that without having to talk to the supervisor because they really don't want to feel comfortable yet, just having that conversation.
It's a true peer model. Makes sense. Everybody has a voice and needs to be respected and heard.
Right.
Yeah, definitely. If anybody amongst our participants has a question, oh, do you have any team members that might be in our attendees group?
Let's see here.
I don't want to miss anybody.
I don't see anyone.
Okay.
Hmm.
All right. So again, if anyone wants to raise their hand or post a Q&A comment question, now's the time. Otherwise, I do thank you both so very much for your time
Thank you.
and
Thank
this wonderful presentation.
Thank you so much.
And it will be posted on NAMI New York City Staten Island YouTube page for our family and friends that weren't able to come tonight. And so thank you so very much.
Thank you. It's a pleasure.
All right, and have a wonderful night. And I look forward to networking with you both soon.
Yeah, same here.
Okay.
Have a good evening, everyone.
Yes.
Good
Good night,
night.
everyone.